Welcome to Legal Nurse Podcast. I have with me today Jenna Gaines, who is a doctorally prepared nurse practitioner who works in the area of cardiology. And as we were planning this podcast, we were thinking about the all too common medical problem of people who come to a healthcare provider and have chest pain or other symptoms of an MI, and tragically get misdiagnosed at times. Jenna and I decided we wanted to do laying some background information to help you as a legal nurse consultant when you are looking at a case involving this type of outcome. Welcome to the show, Jenna.
Thank you. I'm happy to be here.
Let's first of all say, what exactly is an MI?
Yeah, good question. So I think it's important to know, what are we talking about when we talk about missed or delayed diagnosis of an MI? Specifically, an MI, myocardial infarction, we like our abbreviations in healthcare, also known as a heart attack more commonly, refers to the damage to the heart tissue called the myocardium. So specifically, there is a process by which the heart's arteries, called coronary arteries, have an event occur. Some plaque can rupture, the artery can dissect, there can be a thrombus that is lodged, and unfortunately, this leads to a blockage within that coronary artery and eventually death of the heart cells called the myocytes.
All right, so there's quite a few mechanisms of injury there that you're describing.
Yes, there are.
Are there different types of MI?
Yeah, there are. Acute coronary syndrome kind of breaks this down quite well. So there is a STEMI, known as the abbreviation for ST elevation MI. And this is where the ECG shows elevation in a certain segment of this ECG. And this is kind of the most concerning MI. And this is treated like a emergency. Then there is the NSTEMI. The full spelling out of that is non-ST elevation MI. And this, you'll see ECG changes where they can be depressions in the ST segment instead of elevations, or transient ST elevations, as providers are doing serial ECGs when they're concerned, when they're working up a patient for an MI. You might see findings that come and go. Or in another segment, you might find T-wave inversions on the ECG. And lastly, there's unstable angina. This is the patient who presents with a very concerning story. You're like, this must be cardiac. You know, the pain they describe, location, when it occurs, that kind of thing is very concerning. Yet on the serial ECGs and the blood work that is being done, there are no findings consistent with an NSTEMI or a STEMI.
All right. I know that when a person comes into the emergency department, there's a whole series of tests that are done to try to narrow down what exactly is going on. Can you give us an overview about what those would be?
Yeah. So how we diagnose a myocardial infarction is very black and white. As you kind of guessed, the ECG is the most important thing. So the patient comes in to the emergency room complaining of chest pain. The first thing that's going to be done by the technician or a nursing assistant is that ECG, and that goes straight to a provider who evaluates it and makes a decision as to how concerned they are with the clinical picture. Can they wait in the lobby? Do they need to be roomed right away? Next is the cardiac biomarker. So we do blood work. There's a bunch of different labs that are going to be done to kind of evaluate if other things might be going on as well. But namely, the cardiac biomarker that we're concerned about in the diagnosis of the MI is called a troponin. And there are different types. There is the new high sensitivity troponin. Without getting too specific, we've got some good tools in our toolbox as of late. And then the story the patient tells. So once the provider is able to meet with the patient, the story that they provide is super important to the clinical picture. So the ECG might be showing us something, the blood work might be showing us something, but we want to know, where's the pain? What does it feel like? Does it radiate anywhere? Are there any shortness of breath or associated symptoms? the severity of the pain. Does it come and go in certain instances? When does that happen? So that story that the patient tells, that history, is very important in the diagnosis. Next is the physical exam. The provider is going to do, a normal physical exam. Listening for any abnormal heart and lung sounds is key. And then not necessary in the diagnosis of an MI, but most patients who go to the emergency department end up getting a chest x-ray. And this can be useful to find out if anything is going on that is related to the clinical picture or is completely different than the story the patient's telling.
Mm-hmm. And I know that when people come in, particularly to the emergency room, there are some special circumstances, or there are statements that they make that cause everybody to go, whoa, tell us about those.
Yeah, definitely. So patients can present to their primary care office, cardiology clinic for a routine visit, or urgent care, or the emergency department. The things that you're going to look for are all the same in that initial workup. Kind of asking the patient about that nature of that chest pain, that's definitely a whoa moment where you're going to want to find out more about the story that they're going to tell you there. The cardiac history, do they have a prior history of stents? Do they have a prior history of a bypass surgery? That is very important in your workup. You're going to kind of treat that differently. Their presentation might even be different if they have a cardiac history. So that's very important to look into. Their medical history, surgical history. So are they diabetic? Do they have hypertension? Their own medical history is also very important. And then the family history. So you have some kind of atypical presentations, and some of those might be a young patient in their 30s, and you might not be thinking chest pain, heart attack. But if they say, hey, every male in my family has had a heart attack in their 30s, those are the questions you want to be asking, because that's going to clue you in to what's going on with the patient. Their social history is very important. Do they smoke tobacco? That increases their risk. So if you're a little on the fence, kind of looking at those risk factors of their history, like hypertension, diabetes, do they smoke? Do they drink alcohol? And do they use any illicit drugs? Have they used any recently if they do? And then the baseline ECG. So yes, you're going to get an ECG when they come into the office or the emergency room, but have they had prior ECGs? You want to compare that. Does it look a little abnormal, but is that what it always looks like when they have an ECG done? Or are there new findings? So that comparison of the prior kind of baseline ECG is very important. And then again, the physical exam, any abnormal findings you have are going to kind of clue you into some special circumstances that might be going on.
Something you said a few minutes ago really struck me. Every male in my family has had a heart attack in the 30s.
Yeah.
And what is it like to have that hanging over your head? I wonder.
It's tough. Different patients handle that differently. I have some kind of go-getter patients who are in the cardiology office in their 30s and they want to get checked out, and they're very diligent about that information that they know in their family history. Others try to take care of themselves and hope that nothing happens. But then if they kind of present to their primary care emergency room and they have some symptoms, they might offer that up right away because they know that kind of looming concern that they have knowingness about their family history. So I've seen it handled different ways.
Yes.
It's a tough one.
It is. I know that there has been a big focus in quality of looking at how fast the healthcare system responds from the symptoms that are concerning. And we haven't talked yet about differentiating between GI and MI symptoms. There have been markers about how many minutes should transpire from the time the person gets there to the point that the diagnosis of an MI is made. Can you bring us into that world a little bit and tell us what types of standards are emerging?
Yeah, definitely. So once the diagnosis is made, Is it a STEMI? Is it an NSTEMI? That's really important to differentiate, as you're saying. So the STEMI, well, first of all, patient comes in with chest pain, they have to get an ECG within 10 minutes. That's kind of guidelines. And so all emergency departments kind of frame their workflow around that. So if someone presents and that's their main complaint when they check in, they'll get that ECG that'll be sent back for a technician to grab them and do an ECG within 10 minutes. Provider reviews it. And if it looks like a STEMI, they get brought back right away and the workup starts immediately. And then the goal is to get them to the cath lab ASAP. And that usually looks like within 90 minutes of them presenting. They say door to cath lab. So as soon as they walk into the emergency room and go to the cath lab, the goal is to get them there within 90 minutes. Now, not every facility has a cath lab. So with that, the goal is to get them to a facility, get some medication started, then get them to a facility within 2 hours to get to a cath lab facility. And then if they're not able to do that and they have a STEMI presentation, we can offer fibrinolytic therapy with the goal of getting them to a cath lab facility within as many hours as possible. So some tools there to kind of augment what we're working with depending on how, if you're in an urban facility or not. And then for the NSTEMI, if the patient has stable symptoms, then they're usually going to get medication started. They're going to get up to a telemetry floor and see how they do with the medications, depending on if the presentation is early or late, meaning did they have symptoms a week ago or did this just happen? They'll end up going to the cath lab, usually within a 12-hour time frame.
As I think about the way that people can be scattered in rural areas, if you're in the middle of Montana or Alberta, Canada, or you're in the outback of Australia, where we have listeners, how can we get around that, I guess, is the question. In other words, what's striking me is your chances of survival are highly dependent upon where you are at the time you're having symptoms. Can you comment on that?
Yeah, it's a great question, Pat. It's something that we kind of deal with in healthcare often, and it's one of those disparities. We have many, unfortunately, in healthcare, and where you live, although you may love where you live, might be the most beautiful place on earth. If it's not near an urban center, you don't want to think you pay the price for that, but it's definitely a concern. So what healthcare has done is they've tried to include things that we can do to get care started as soon as possible. So there's different medications, anticoagulants, antiplatelets, beta blockers, stuff like that. Medications that are started as soon as a patient is diagnosed with an MI. And so they're getting treatment. It just might not be the cath lab treatment that they need in quite the timely fashion that we recommend. But we do get medication started, and we do offer different types of IV therapies, like those fibrinolytics that I mentioned, to try to kind of bridge the gap and the time frame to when they can get to an urban center that has a cath lab. So this is just one of those. It may kind of delay care to some extent, but you're working with the resources that you have available when you present to a certain healthcare facility.
Yes. Well, as legal nurse consultants, we can get involved in cases in which there could be delays in treatment, there could be delays in diagnosis, there could be misdiagnosis. What are some of the common types of conditions that are associated with a misdiagnosis of an MI?
Yeah, great question. And this is a tough one, right? I think that, that miss or delayed diagnosis because the presentation looks and sounds like something similar is really tough. It's tough for the patient. It's tough for the provider. And not everyone presents with that typical chest pain picture. Some of the things that can kind of cloud the picture, I say mimickers of the MI, would be GI disorder. So reflux, surprisingly reflux can kind of mimic an MI. Stomach ulcers, esophageal rupture, that's a true emergency, but that pain can be described as chest pain, and it radiates across the chest, and it can sound very similar to an MI. And so the workup of that can lead you down the wrong path for sure. Other lung disorders can be a mimicker of an MI as well. Pulmonary embolism, that's a clot in the lung. Pneumonia, which is an infection in the lung. And pneumothorax, which is air in the lung. All of those can present very similarly, especially because with the lung disorders, you're going to have some shortness of breath. And with an MI, patients often have shortness of breath. So that can also kind of cloud the picture. And just dissecting aortic aneurysm can present very similarly to an MI. Electrolyte abnormalities, I think I mentioned there's a bunch of blood work that's done other than just the cardiac biomarkers. So you can find ECG changes with electrolyte abnormalities that can be very confusing if the provider's not noticing all of the blood work. You'll still find ECG changes with electrolyte abnormalities. And drug use, we talked about kind of obtaining that good social history. There are various drugs that can mimic an MI. Cocaine specifically is one that comes to mind. So asking patients about that kind of prompts the provider to do a urine drug screen and investigate if that could be something that's coming, that is going on that might mimic the chest pain picture. Psychological disorders, this is a really tough one. Younger patients, unfortunately, often get kind of labeled as being anxious or panicky. And it can be kind of, it can cloud the picture of the symptoms they describe, because chest pain is often something that goes along with a panic attack. Musculoskeletal pain. So you can ask kind of patients about what they've been doing recently. Do they play any sports? Do they work out? That kind of thing. Have they recently been sick and coughing, and kind of working those muscles in the chest wall cavity can lead to costochondritis, and that can present very similarly to an MI because you have chest pain that you feel with that. So there are many more. These are a few. But it's tough because they all are, like I said, they mimic that MI picture, and it can definitely lead to a misdiagnosis and kind of cloud your workup of what you're doing for the patient.
And then take us into the question of a delay in diagnosis. What are some of the factors that can influence coming to the right diagnosis, but much later than would be ideal?
Yeah, exactly. So working up another condition other than an MI. So if you don't see any ECG changes initially, the provider is going to look for other diagnoses that can explain the chest pain that the patient's coming into their unit with. So working up that condition, any of the ones that I just previously mentioned, can take time away from the diagnosis of an MI and delay the care. The atypical presentation is key. So we say non-cardiac chest pain now instead of atypical, versus a typical presentation we think of as the true cardiac chest pain. So with the non-cardiac chest pain, we can see patients who present like women. Women will have a different pain that they feel with an MI than the typical like white male that has been studied for decades and decades. This can definitely delay the diagnosis because the story that the patient tells maybe doesn't key the provider in to an MI. Dialysis patients, they can have chronic elevations in their cardiac biomarkers, that troponin, that can definitely delay diagnosis. Young age, like we mentioned earlier. So patients who come in, not the typical patient you think who's going to have an MI, but if you ask the right questions, find out they have a strong family history, that'll get you to your answer a lot faster, whereas you might get a delay if you're working up their chest pain being a panic attack or something like that because they are younger. Initial testing being negative, this one's big. Like I mentioned, the initial ECG might not be positive. If the patient is really in tune with their body. We get some patients who come into the emergency department very early and you don't see any elevations in their troponin yet. So if nothing in the workup of a different diagnosis is helping with the diagnosis, repeating the ECG, repeating the blood work, kind of doing that serial testing will help you get to your diagnosis. But all of this can definitely delay the care the patient receives if they are having an MI.
And you can see from a liability perspective, if somebody comes in with classic symptoms and the providers miss it, it's very clear cut. But it seems like what you're defining just now is some of the grayer area that we can get involved in. Before we continue with the show, I'd like to share this special announcement with you. This is Pat Iyer with Legal Nurse Podcast. I have with me Penny Hopkinson, who is a freelance procedure manual writer based in the UK. We have just finished her podcast, and I know you're going to find the ideas that she expresses in this podcast to be perhaps mind-blowing, revolutionary. Like, why didn't I ever think of that for my own business? Penny, what were some of the concepts that we covered in your podcast?
Well, they were the concept of quality and how by writing procedures, by documenting the processes, you'll become more competitive, efficient, and other people will be able to run your business if you are unable to do so. And there is a distinct process where we cover 4 main pillars, which are people, marketing and promotion, day-to-day operations, and growth and profit. And everything falls into those categories.
You'll get some great tips on writing procedure manuals and the importance of having these documented for your business by checking in with Penny Hopkinson's podcast. You'll find that right here, right below this list, if you are clicking down and listening to podcasts in a series of shows, or come back next week when you'll get an opportunity to pull out those pearls of wisdom that Penny has shared about policies and procedures. I like that alliteration, Penny. We've got pearls of wisdom that Penny shares and policies and procedures. Yes. Thanks so much, and I'll see you next week. Now let's return to the show.
Yeah, definitely. And that's kind of, looking into those details in a case. Every LNC will be looking for, how it was diagnosed, timing of diagnosis. It's going to be huge for that attorney in that case and that client to make sure that the care they received was standard of care.
Mm-hmm. And then, of course, the ultimate question in evaluating any case is, what are the damages? I've just finished teaching a course on helping legal nurse consultants write different types of reports. And we've gone through the 4 elements. It's easy to establish that the providers had a duty to the patient. But then the next question is, what are the damages? What were the consequences of this?
Yeah, definitely. So I'll start with the worst. I think if you have a missed or delayed diagnosis of MI, this is, it can be lethal. So death is a possibility. And this is where you're looking at your wrongful death cases. Was the misdiagnosis of the MI or the delayed diagnosis of the MI, did that lead to wrongful death? Heart failure is another one. So the delay in diagnosis can cause more damage to the myocardium, that heart tissue that we were talking about earlier. And that can lead to heart failure over time. This impacts quality of life, patient survival over time. That's a big one. Another one is arrhythmias. We all know that patients with heart attacks can have a code, require CPR, resuscitation. So timing of door to cath lab is super important to try to prevent these arrhythmias. So if there's a delay in diagnosis or a patient is misdiagnosed and treated for something else, the concern is if they leave that emergency room without proper diagnosis and treatment, they could go home and have a lethal arrhythmia and code at home, and hopefully there's bystander CPR, but there's a whole cascade of stuff that can happen with that. So we worry about those arrhythmias in patients who have heart attacks. The next one is cardiogenic shock. I think there's a concern for patients who have a delay in their diagnosis. We know that we want the timeliness of treatment for a heart attack to be kind of center of care, because any delay is going to put further undue stress on the heart, and this can lead to a shock state. And lastly, valvular disorders. So during the course of an MI, depending on the location of an MI, the heart muscle kind of goes out, so to speak. And that can put undue stress on the valves while the heart's still trying to beat and contract and do its normal job. And that can happen either acutely or over time. We can see damage done to a valve, and possibly down the road, maybe repair is necessary. For patients who survive an MI, if there's a delay in that standard of care, the outcome can be detrimental to patients. So I think it's important. This is where the LNC is looking for those details in the case of a patient, that presentation, the care they received, the timeliness to kind of establish if that standard of care was met or not, and where those consequences come in.
Well, you've covered an area that can have huge consequences in terms of the health of the person who has a delay in diagnosis or a misdiagnosis. It's such a critical area that we do right in healthcare, whether it's an urgent care center or an ER or a family practice office or some other setting where rapid recognition and treatment is so essential.
Yeah, I completely agree. I mean, I hope that's a takeaway. No matter where the patient presents, anyone can start this workup and get the patient the care they need to kind of meet that timely care.
How can our listener find out more about you and the services that you offer, Jenna?
Yeah, I think the easiest way is my website. It's gaineslnc.com. So G as in golf, AINES, LNC.com.
Okay, perfect. And do you provide expert witness services?
Yes, I can. Mm-hmm.
Very nice. Well, thank you for putting the spotlight on an area that is so critical and can lead to such tragic consequences if not appropriately treated. You've defined for us what is clearly a very complex area of clinical medicine. And I think it'll be useful for somebody who is working up a case or screening a case for malpractice, looking at what happened to the patient and what should have been done versus what was done.
Yeah, I completely agree.
And to you who's been listening to this program, be sure to request the transcripts. If you are not already receiving them, you can get them from our website by going to podcast.legalnursebusiness.com and come back next week for a new show. This is Pat Iyer with Legal Nurse Podcast. I have with me Jenna Gaines, who is a doctorally prepared cardiac nurse practitioner, and we've been talking in her podcast about some of the nuances of diagnosis and treatment of MI and how a failure to diagnose or a delay in diagnosis can have significant impacts on the patient. Jenna, could you give our viewer or our listener just a couple of highlights of what we covered in your podcast?
Yeah, definitely. We covered a lot today. We discussed the definition of an MI, the diagnosis of an MI. We discussed the initial workup of an MI and what providers specifically should be investigating in the patient who presents to them with chest pain. We discussed the type of the acute coronary syndrome and the treatment for each of those. We discussed conditions that can mimic an MI and how this leads to delay in diagnosis of an MI or misdiagnosis of an MI. And finally, we discussed that atypical non-cardiac patient presentation that can lead to misdiagnosis of an MI.
As you can tell, we covered a lot in Jenna's podcast. Be sure to catch her show on Legal Nurse Podcast. You can get it directly from podcast.legalnursebusiness.com.